Hello everyone. Welcome back to another episode of Dental Digest with the Study Boards. I'm Dr. Trehan, and today we are continuing our series on odontogenic cysts, and our focus is going to be on a very interesting but misunderstood topic, the orthokeratinized odontogenic cyst, or OOC. So here is how the breakdown of this video is going to be. We are going to talk about its origin, pathogenesis, clinical features, radiographical features, histopathology, some complications, the treatment, and finally, most important part, differential diagnosis. Let's start by understanding the origin and etiology of orthokeratinized odontogenic cyst, or OOC. Now, these cysts are developmental in nature, meaning they form during the growth and development of the teeth and the jaws, and they originate from the remnants of the dental lamina, specifically the rests of caries. Now, while the exact cause is not fully understood, but what we know so far is that OOCs are extremely rare. Therefore, you're not going to get any question on the etiology in the examination. Let's understand how the OOC develops step by step. Now, it starts with the rests of caries, which are left behind after normal tooth formation. And in most cases, these cells stay quiet, but sometimes developmental changes trigger them to proliferate and form a cyst. Now, unlike inflammatory cysts, there is no infection or trauma involved. This is purely developmental process gone off track. So the key characteristic here is orthokeratinization. That is, the cyst lining produces orthokeratin, not parakeratin. And that's the big differentiator between the OOC and the OKC. Same general family, but different epithelial behavior. Now let's break down the clinical features of OOC step by step. First thing is they are painless and asymptomatic. Most of the patients really don't feel anything. So the cyst is usually found by accident or an X-ray that has been taken for any other reason. And occasional swelling in some cases could be present, which is very localized, but still no pain, so the patients often ignore it. But it's also at times linked to eruption delay. So sometimes you'll see it associated with an impacted or unerupted tooth, which can delay eruption. But don't confuse it with that of dentigerous cyst. As far as the age group goes, most commonly they are seen in adults between 20s to 40s, and gender predilection is going to be males. About 3 males for every 1 female. Now the overall picture that you have to understand so far, it's a silent, slow growing, often incidental and more commonly occurring in young to middle-aged men, and that's what makes early radiographical screening very important. Now let's go step by step through radiographical features of OOCs. As far as the appearance goes, they usually show a well-defined unilocular radiolucency, a single dark area on the X-ray. Now border-wise, the edges are corticated, meaning that there is a thin white outline separating the cyst from the bone, and that clean border makes it easy to identify. As far as tooth association goes, around half to 3/4 of the cases are linked to an unerupted tooth, most often third molars. So always check for a cystic change that's happening around an impacted tooth. As far as location goes, these cysts really love the posterior mandible, especially around the molar and ramus area. So remember, posterior mandible, unilocular, corticated margins, and often linked to an unerupted tooth, and those are going to be our radiographic hallmarks. Let's break down the histopathology of orthokeratinized odontogenic cyst step by step. The first thing is the lining is thin, orthokeratinized, stratified squamous epithelium, and that's going to be your main differentiator from the OKC, which has parakeratinization. Now beneath the surface, you will find a granular cell layer filled with keratohyalin granules. Very important. And these are what creates that lamellated keratin, the classic onion skin pattern you will see in the cyst lumen. The basal layer is made up of cuboidal to flat cells, and here is what's important. It does not show palisading or those dark hyperchromatic nuclei like an OKC. That's a differentiating factor again. And the surface is also smooth, not wavy or corrugated. Now the cyst wall is fibrous, usually non-inflamed, and provides support without any aggressive features. So in summary, orthokeratinization, granular layer, smooth surface, and no inflammation, and these are going to be the hallmarks that confirm an OOC and explain why it behaves in such a benign manner. Now let's talk about some complications that can arise in OOCs, and honestly there are not many to worry about. It has a low recurrence rate. About only 2% of the cases come back after treatment, mostly because these cysts are very well circumscribed and easy to remove completely. They are non-aggressive, so they are really not invading the bone, or they're not spreading into the soft tissues. They stay where they are, very localized, and prognosis is very favorable. And when you're comparing it to that of odontogenic keratocyst, OKC, which can behave like a tumor, the OOC is a calm, predictable, and very easy to manage kind of a lesion. So overall, minimal recurrence, no invasion, simple management, and that's what makes OOCs benign and reassuring as far as the diagnosis goes. Now let's talk about the treatment of OOCs. First of all, the treatment is going to be very simple. Simple surgical enucleation, that is, the entire cyst and its lining is carefully removed. And the reason is the cyst is very well defined, so it separates easily from the bone, making the removal very straightforward. So no aggressive surgery is really needed. Unlike OKCs, OOCs really are not invading the bone, so no extra bone removal or resection is even required. So in short, simple enucleation, predictable healing, and excellent prognosis is how we are going to feature it. So in short, think of it as simple enucleation, predictable healing, and excellent prognosis. Now let's go step by step through the differential diagnosis of an OOC. So when you are going to see a well-defined radiolucency near an unerupted tooth, a few other lesions can look very similar. So here is how you're going to tell them apart. First of all, dentigerous cyst. It's also linked to an unerupted tooth, but it actually wraps around the crown at CEJ. Its lining is thin, non-keratinized, and the cyst wall is less fibrous than that of OOC. Then we have to think about OKC. Now this one can look almost identical radiographically, but the lining is parakeratinized, not orthokeratinized, and the basal cells are palisaded and darkly stained. Now clinically, OKCs are more aggressive and have higher recurrence rate, while OOCs behave benign and rarely come back. Now the next differential diagnosis to think about is ameloblastoma, and this is a benign tumor, not a cyst, and it can actually still appear as a radiolucent lesion, and the key difference is that it usually causes bony expansion and its histology shows epithelial islands and that stellate reticulum-like cells, findings that are never seen in OOC. So in short, check the tooth's relationship, epithelial lining, and the behavior. And those are the three clues that will help you separate an OOC from its lookalikes. So let's discuss some key points now. Now to summarize, the orthokeratinized odontogenic cyst or OOC is a rare developmental cyst from rests of caries. Now clinically, it's painless, asymptomatic, and usually found in adult males during routine imaging. Now radiographically, it shows as a well-defined unilocular radiolucency, often in the posterior mandible and sometimes around the unerupted tooth. Then histologically, it has orthokeratinized epithelium with a granular layer, lamellated keratin, and no inflammation. It's benign, non-aggressive, and rarely recurs. As far as a treatment choice goes, enucleation is the treatment of choice with an excellent prognosis. Then you have to know how the differential diagnosis has to be done from dentigerous cysts, OKCs, ameloblastoma, based upon the lining and behavior and histology. Thank you so much for watching this episode. If you found it helpful, don't forget to give it a thumbs up and subscribe to the channel for more Dental Digest videos. Drop your questions or thoughts in the comments, and I always enjoy hearing from you guys. Keep working hard, stay consistent, and as always, keep rocking. I'll see you in the next one.